afternoon, everyone. Hi, welcome to everybody.
Hello.
We'll just give it all a couple of minutes, but you have all been put on mute. So if you could please remain on mute, just so there's no background noise, that would be great. And we'll just give people a couple of minutes to keep joining us, and then we'll kick off the session. But welcome, everybody. It's lovely to see you all.
Lovely sound of birdsong somewhere too.
I think that might be me, actually.
As long as it's real birdsong and not fake birdsong, that's fine.
It's definitely, I've not got my whale music going on in the background for it. Okay, so I think most people here will let a few people in a couple of minutes, but it's a busy session, so I want to make a start. So first of all, good afternoon, everybody. Thank you so much for joining us. It's lovely to see so many of you here on this, I hope, sunny afternoon where everybody is. We really hope you get a lot from this session. As I've said, please be aware that you are muted. Please do remain muted because it can become quite distracting. The session is being recorded, that's so we can put it on our YouTube channel after the event. So if you miss anything or you want to go back over anything, it'll go onto our YouTube channel next week. We're joined by the wonderful Professor Anne MacGregor today, who will be sharing some presentation, showing her slides in a presentation with us, and then we'll move on to a brief question and answer session at the end. So if you do have any questions, please just pop them in the chat box. We won't be doing them by speaking out, it will just be in the chat box, and then my colleague Mags will be putting your questions to Anne at the end of the session. We'll be sending out an evaluation form at the end of the session. I know it's a bit of a pain and nobody ever really wants to do them, but they really do help us shape the events moving forward. So if you could just take a couple of minutes of your time to fill it in after the event, that would be great. If we don't get to all the questions, I'm really sorry. Like I say, it's a really busy session, so we might not get to them, but please feel free to use our helpline and our email service. The form is on our website, and we can take those questions offline and we can try and get back to you to answer those questions. We will try and get through as many as we can, but apologies in advance if we don't get to yours, but please do use either of those services. So without further ado, I will hand over to you, Anne. Thanks very much.
Okay, thank you very much. So let me just share my screen, everybody. So, well, thank you very much to everybody. Thank you to Migraine Trust for enabling me to give this talk about women and migraine. And it's something I do feel quite strongly about, that the effects of female sex hormones on migraine are considerable and should be taken better notice of. Now, I also appreciate that each of you who has come to listen to this talk will essentially have your own experience and your own agenda of what you want to hear me say today. And I recognise that I may not be covering all of those aspects. So do forgive me, and I'm sure if you feed back to Migraine Trust with any other specific topics you'd like to hear at future presentations, I'm sure they will be happy listeners on that front. So let me move on to the next slide, and this is really telling you what you know already. This is looking at the prevalence of migraine in women versus men at different ages. And you'll see quite clearly the females, the women are red and the males are the blue. And you'll see there's roughly about 3 times more women than men who are experiencing migraines. And you'll see peaks of prevalence as well. So not surprisingly, prevalence will peak following the first onset of a migraine attack. So sort of peaking in prevalence in early 20s in women, a little bit earlier. Women have to wait for their migraine to come on a little bit later than the men. And then we do see another little peak you will not be surprised around the time of perimenopause. More on that a little bit later on. So I guess the first question to ask is, why does migraine affect more women than men? And I think it's useful here just to look at estrogen levels over a woman's lifetime and how that fits into the timing of those peaks of prevalence that we've actually seen. So we know that estrogen levels mirror changes in migraine prevalence. So you'll see on this right-hand side of the screen, we see fluctuating estrogen levels that's building up from childhood, building up through puberty, where it starts to become a little bit erratic as the system is gearing up to the first menstrual period. And then it takes another few years to begin to settle down. And it's that time we see new onset of migraine. Similarly, when hormones become spiky and erratic during perimenopause, and believe me, while all the pictures suggest that hormone levels, estrogen levels, suddenly decline during perimenopause, that is just not the case. They can become very erratic and they can actually spike quite high during perimenopause, and this is associated with the increase in migraine that we see. And in particular, it's around this time that we see an increase in menstrual migraine. And when I talk about menstrual migraine, I'm talking more about it in the women who have natural cycles who are not using any hormonal contraception or other hormones. So what do I mean by menstrual migraine? Because that can make you just assume that it's only migraine that you get while you're having your menstrual period, and it's a little bit more complicated than that. So this is some research that we did back over 15 years ago, where we looked at the percentage of women reporting migraine on any particular day of the menstrual cycle. So day 1 is the first day of bleeding. There is no day 0. And as we shift left across the graph, we're moving to the days before the first day of the menstrual period. And you'll see that I've also marked the likely time of ovulation at that point. We don't see a significant rise in migraine days associated with ovulation. But what we do see is this significant time around this first day of menstruation where there is an increase in migraine attacks. And these perimenstrual migraine attacks start on or between a couple of days before the first day of menstruation. So I guess that's why the term perimenstrual migraine is better than menstrual migraine, because the likelihood of migraine starting occurs before this first day of menstruation. And it's still rising, so there's incidence of a migraine day on the first 3 days of bleeding. So this is where the figures day -2 to day +3 come from. And note there is no day 0, -2, -1, first day of menstruation, and then days 2 and 3. So definition of menstrual migraine is perimenstrual attacks. And this is another important bit that often gets forgotten, is that occur more often than expected by chance. So if a woman is having very frequent migraine attacks, it is quite possible that they could just by coincidence be having menstrual attacks, perimenstrual attacks as well. And that is not what we would define as menstrual migraine, because a hormonal drive for those non-chance events, or sorry, those chance events is unlikely. How do we identify it? We identify it incredibly simply. So this slide is just a picture, if you like. It's a diary. I'm very fond of using this type of diary. And you'll see for every day of the month, there is a square. And on the diary, a woman just records a circle for a day of her menstrual bleeding, and a cross for a migraine. You can add on other keys as well. So you might want to put a slash, if you like, for a headache that's not a migraine, a smaller circle for spotting. You can really include any additional pieces of information that you like. But what this diary shows me is that this woman has very regular menstrual periods, because you'll see that there is a sort of diagonal, like a forward slash, if you like, with a pattern of menstruation. So that means she's having roughly 28-day cycles. I can see that her bleeding goes on for about 5 days. And I can see that she has more crosses on her bleeding days than she does at other times of the cycle. I can also see that the duration of migraine attacks with her menstrual periods are longer than the duration of attacks at other outside of that bleeding, that period time. So if you look at the crosses associated with the circles, you'll see that they are often lasting a good 3 to 4 days, whereas ones at other times of the cycle are maybe only 1 or 2 days. So that is a very clear pattern of menstrual migraine. And importantly, in women who are diagnosed with this true association between migraine and their menstrual periods, we see a number of significant differences in each individual woman's menstrual attacks versus the attacks that they experience at other times of the cycle. So they are less likely to be pain-free at 2 hours with their menstrual attacks. They are more likely to relapse at 24 hours after they successfully treated the migraine attack. It's more likely to come back the next day. They're more likely to need more symptomatic treatment and rescue treatment. The associated symptoms such as nausea, vomiting, sensitivity to light, disability are much greater. The risk of it being severe is greater, longer than 3 days duration, and highly significant with differences between disability as well. So these perimenstrual attacks are a different kettle of fish, if you like, from the attacks at other times of the cycle. They are much more troublesome for women, as those of you who experience menstrual migraine will know. Now, just the utility of the diary as well, it can also help us see patterns even in women who are not having regular menstrual periods. So this is the diary from a woman who's in late perimenopause. She may be skipping sometimes a few periods, not in this category, but you can see how irregular her periods have become. We've lost that pattern. You can still see that there is this clearer association between the menstrual migraine attacks, still of longer duration, migraines clustering around the time of the menstrual period, and those that are occurring at other times of the cycle are shorter. So these very simple diaries can be incredibly useful at very quickly helping us to identify what's actually going on with individual women. So let's move on to what causes menstrual migraine. So forgive me for doing a bit of a biology lesson here, but I think it's helpful just to take you through what goes on, what drives the menstrual cycle and what drives menstrual migraine. So I'm going to do a little bit of biology, looking at how the brain and the ovaries work together to trigger off these menstrual attacks. So here we have everything that's going on in the brain. And I'm going to just highlight the hypothalamus here, because the hypothalamus is where a migraine attack starts from. It's the sort of initiating the premonitory symptoms that we experience of feeling extra tired, yawning, feeling hungry, thirsty. These are all hypothalamic symptoms. And this is the key part of the brain in the sense of where migraine comes from. And the hypothalamus you need to think of, if you like, as the master of your, or conductor, if you like, of the hormonal orchestra within the body. And it's sending messages down through to the ovaries. So particularly from the pituitary gland, hypothalamus sends messages to the pituitary. Those messages, the hormones, luteinizing hormone, LH, follicle stimulating hormone, FSH, they drive the ovaries, and the ovaries then produce the hormones estrogen and progesterone across the menstrual cycle, and then we get feedback to the brain from those hormones, and that perpetuates the cycle again. And with respect to what we see as changes associated with triggering migraine, it's very much the ovarian hormones rather than the brain hormones that we see driving or triggering menstrual migraine attacks. So from that bit, I'm just going to put it in a little bit of a different context to take you through, if you like, what goes on during the menstrual cycle. So the two red bits here, the two columns here, are a menstrual cycle, 5 typical days of menstruation. And you'll see it's divided into 3 phases. The follicular phase, which is the early start of the menstrual cycle. Ovulation, obviously where a woman releases an egg if it's an ovulatory cycle. And then what we call the luteal phase, which is the second or last main part of the cycle, leading up to the start of the next menstrual period. And here I've just superimposed on this the time that we see this increased risk of migraine. So here's our menstrual cycle hormones. I'm just going to be looking at estrogen and progesterone because they are the main potential protagonists in this scenario. So we see that estrogen will generally start to rise during the follicular phase. It will then have a faster rate of rise around the time of ovulation, followed by a little dip, and then a more sustained rise in the luteal phase, dropping down again before the next menstrual period when the body identifies the woman isn't pregnant. And then progesterone is really only released in cycles when a woman ovulates. Following ovulation, progesterone levels rise. And again, when the body identifies that a woman isn't pregnant, those levels drop. So here we have 2 hormones, estrogen and progesterone, that are the most likely factors to be implicated in this increased risk of migraine at this particular time of the menstrual cycle. So can we work out a little bit further as to which, if either of these hormones is relevant? Does migraine follow the drop in estrogen or the drop in progesterone, or is it a mixture of the two? So just again, looking at it in a slightly different picture again. So we're looking at the first day of menstruation, 5 days of bleeding. We see the purple line, which we see the late luteal drop in the level of estrogen, and we see the late luteal, the black line, drop in the level of progesterone. And then we see in the natural cycle, the estrogen levels, the purple ones, will rise again to ovulation, followed by the drop. So I've charted on here the increased rise in migraine. So what happens if we stop that or block that drop in estrogen at that time, and we raise the estrogen levels with supplementing estrogen with estradiol gel, which is what we did in a clinical trial, again, about 15 years ago. And what happens is you'll see that while we're giving the gel, the estrogen levels rise, but there then is a delayed drop in the estrogen levels. And it's at that time, again, that we see an increased risk of migraine. So even though progesterone levels have fallen at the expected time, and that has triggered off the bleed, actually, if you then alter the pattern of the estrogen, the increased risk of migraine is shifted to when we have the delayed drop in estrogen, irrespective of the progesterone. And there were some further studies done back in the 80s to look at what happened if you delayed the drop in progesterone, and suffice to say that migraine followed the drop in estrogen irrespective of the shift in the drop in progesterone. So putting that together, what does that tell us? Well, it tells us that migraine follows the drop in estrogen and not the drop in progesterone. So this, an important point to realize, is that we can trigger estrogen withdrawal migraine irrespective of when the menstrual bleed occurs, because that tends to be more related to the drop in progesterone rather than estrogen. So estrogen withdrawal migraine is one of the mechanisms that happens to be associated with menstrual migraine. And you'll see I said one. So are there any other mechanisms that may be involved? Well, we know that people are beginning to look at a number of other mechanisms. They're looking at other hormones called oxytocin, for example. But there is one that we have definitely identified on a clinical basis, and that is another hormone called prostaglandin, or prostaglandins, if we consider the group of them. So what do prostaglandins do? Well, prostaglandins are a hormone that gradually rises, the levels of it increase about threefold across the menstrual cycle, with the maximum release during the first 48 hours of menstruation, first 48 hours of when a woman bleeds, which is the time that we're seeing this peak increase in perimenstrual migraine attacks on that first day. And prostaglandins are associated with painful and/or heavy periods. That's prostaglandin release. If I gave an injection of prostaglandin to anybody, they would get pain. It can cause pain and it can trigger off, not surprisingly, migraine attacks as well. So why is menstrual migraine more prevalent during perimenopause? Well, the answer to that, if we just look at estrogen levels, is that we see during perimenopause higher levels of estrogen compared to premenopausal. So if we look back at the follicular phase, which is the early stage, early part of the menstrual cycle, during perimenopause, higher levels of estrogen then compared to previous reproductive cycles in younger women, and then exactly the same just premenstrually in that late luteal phase. And these levels become significant. So being aware that these levels drop, it's the fall in the level of estrogen that is relevant at this stage. If you've got high levels to start with, you're more likely to have a fall that can cross that threshold and triggering off the migraine. We also see an association between hot flushes and night sweat symptoms that again is different in migraine women versus controls. So we know that migraine predicts hot flushes and night sweats. So unfortunately, if you are a migrainer, you are going to be more likely to experience flushes and sweats as part of your perimenopause, and vice versa. Those women who experience flushes and sweats are more likely to experience migraine. And this is a marker, if you like, of the instability of the blood vessels in response to the hormone changes. So again, in late perimenopause, migraine women are more likely to experience hot flushes more than number of days per every 2 weeks. And similarly, again, we see this with night sweats as well. So not just migraine to look forward to in perimenopause, it's the vasomotor symptoms as well. I haven't really touched what happens about the prostaglandins. Well, as women approach perimenopause, we also do see a lot more what we call dysfunctional uterine bleeding, PMS, heavy menstrual periods, and that is also going to increase the likelihood of prostaglandin release as a trigger. So enough of the story behind it. What do we do to manage it? Well, the first thing is we don't start rushing in with hormones. We sit back and we look at, is the woman actually taking effective symptom treatment? because quite often people don't know how to take their symptom treatment properly. We very often take our treatment and rush off and continue doing what we wanted to do in the first place. And that is not the way to optimize your treatment. Treatment, we know from studies that we've done years back when I used to work at the City of London Migraine Clinic, and we used to have patients coming in to treat their migraine attacks from the city, is we knew that if they took their medication and they rested, even just for 20 minutes, just with their eyes shut quietly, that the treatment was more effective in the population who rested or dozed than those who sat there trying to continue on with their work, if that was even possible. So giving yourself a little bit of a break, even just a really short break, is going to make that treatment more effective. Getting your blood sugar up can also make a difference. Your brain is needing energy, it's needing glucose at that time. And while, you know, in normal circumstances, you're not wanting to eat something sweet because it's not healthy, this is not the time to be worried about your diet. You need to get your blood sugar up because that's one of the things your brain is needing. Don't delay treatment. The issues related to medication overuse need to be separated out from early optimal treatment of those who aren't at risk of medication overuse. And quite often we underdose with our first treatment because we're worried about taking too much. You need to front load migraine treatment because otherwise you just end up taking more treatment per attack overall. And bear in mind that with menstrual migraine management, you will be needing to take treatment on consecutive days. A triptan at best will only last 24 hours, and a migraine, if it's going to last a minimum of 3 days, you will be needing to treat over a minimum of 3 days because a single dose of triptan will not last 3 days. You then need to consider prevention, and in these scenarios, we have a collection of options. We have the standard treatments, perimenstrual and hormonal, which I will run through. So standard is where we have women who have a lot of non-perimenstrual as well as perimenstrual attacks, and it can be difficult to glean out how much of a specific link there is between migraine and menstruation. So standard treatments potentially benefit all types of migraine. And I won't go through this list, you'll be aware of these being the typical standard treatments that we have available to us. Although I appreciate that while CGRP monoclonal antibodies are licensed for anybody who has 4 or more migraine attacks per month, they are restricted in the NHS due to cost. So perimenstrual, and this is really targeted towards women who have mostly perimenstrual attacks because it's only going to treat the perimenstrual attacks and not going to manage any of the attacks at any other times of the cycle. And this is what we call sort of targeted short-term prophylaxis, if you like. These are treatments that are taken for several days each month, starting before the expected perimenstrual attacks. And just to run through the ones where we have a body of evidence, bearing in mind, most important bit at the bottom left-hand corner is that none of these treatments are licensed for the management of perimenstrual migraine. These are all treatments that have been used or are licensed for other conditions, but have been shown in clinical trials to be effective in this particular scenario. So Prophylactic taken for 6 days, actually starting a couple of days before the expected onset of the menstrual attack or menstrual migraine. And Prophylactic will then treat all the potential triggers of the perimenstrual attacks. There was a study that we did using estradiol gel. This was, over 20 years ago when we were using it, the same gel that's used for hormone replacement currently, no shortages at that time. And we were using it daily only for 7 days. And that only treats the estrogen withdrawal. But the big problem with that is that we did see this delayed estrogen withdrawal migraine after that treatment was stopped. So it's not something that I would rush to in my toolbox for using in any case, even though the trial data did show some benefit. And the other one is naproxen. Naproxen was the one that was used in clinical trials, but gynecologically we sometimes use another non-steroidal anti-inflammatory called mefenamic acid, although there are no clinical trial data specific to it. And this is really targeted towards prostaglandin release, that it prevents the prostaglandin being released both prior to and during the menstrual period. Problem with that is gut irritation. Naproxen is not very gut friendly and can irritate the gut in certain people, or certainly when it's taken too long. But I guess the biggest problem is that because menstrual migraine is almost by definition particularly affecting women as they approach perimenopause. And when I mean perimenopause, the changes leading up to a woman's last menstrual period are really beginning to start in the early 40s. So average age at last menstrual period is about 52, but these changes that we're seeing are beginning early 40s, and women are not out the other side of hormonal fluctuations even until probably about a good 4 or 5 years after their last menstrual period. There is still ovarian activity, but just not enough to provoke a period. But what I wanted to show you in this slide is each of these little bars represents the variation in cycle length of each of 31 women. So 31 bars here. And this is across 6 menstrual cycles within the clinical trial that you did. I've marked 28 days because that is the average. The mean cycle length was 28 days. But if you take the general population of women, only about 15% of women will have regular 28-day cycles. And if you look at this population of women with menstrual migraine, none of them had predictable 28-day cycles. So the big problem with this is it is so difficult to target premenstrual prophylaxis, short-term prophylaxis, when women can't predict when their periods are going to start. And this is the biggest reason why those types of treatments, even though they've been shown to be effective in clinical trials, are not particularly useful in clinical practice because of the variation of individual cycle length. So if a woman's got irregular periods, what can she do? Well, if the triggers are to do with menstrual cycle hormone changes, logically, to treat the mechanism, we really are looking at suppressing the menstrual cycle as the most effective way of preventing those triggers resulting in a migraine attack. And so this comes back to things I'm sure you'll be aware of: continuous combined hormonal contraceptives. They put the ovaries into a temporary hibernation so that while a woman is taking them, you lose the typical menstrual cycle and you replace it with the contraceptive hormone cycle. And we now have a variety, particularly we don't use patches in this scenario because they can produce high levels of estrogen, but standard low-dose combined pills and the contraceptive ring can be options for women for whom they are suitable for. And I'm not going to go into all the ins and outs of who can and can't take them in the context of this talk, because that just takes too long. You may also be aware is that there is one, what we call a monophasic pill that contains the same hormones every day, that actually contains a body identical estrogen, same type as we use for oral hormone replacement therapy, rather than the synthetic estrogen in the standard combined pills. And we can see this as almost like a sort of contraceptive HRT, if you like, and that can also be very useful at suppressing the natural menstrual cycle. And that can also treat menopause symptoms, and most healthy women who don't have migraine aura can use those to age 50. Sometimes we will use them a little bit longer on an individual selected basis, safety depending. But women who have migraine aura cannot usually use combined hormonal contraception. And for those, we need to be thinking about the progestogen only methods. The reason why we don't jump into using those for everybody is because this slide is actually showing that across time, it is difficult to achieve complete absence of bleeding. So within the first couple of months of using it, less than 10% of women using the desogestrel progestogen-only pill in the standard way will be complete bleed-free, and only about 20% by 1 year. And since bleeding in itself can be associated with increased risk of migraine, we want to try to abolish bleeding at all where possible. So there is a balance between safety and efficacy in this particular population, and there is significant individual variation in this. I put the Mirena intrauterine system in here really just for completeness, because even though it can stop bleeding, it actually doesn't affect the natural menstrual cycle in a significant number of women, and that natural menstrual cycle will continue. And if it does continue, you can still get estrogen withdrawal in the absence of bleeding, and therefore estrogen withdrawal migraine. So you can still see a cycle of migraine even if a woman isn't actually having a menstrual period, but it will help the prostaglandin trigger if dysmenorrhea has been a big problem. What about HRT during perimenopause? So in these years of being in your 40s, it's important to recognize that HRT does not suppress ovarian activity. So essentially it's adding to what your own hormones are doing. And therefore it can actually aggravate migraine in the perimenopause, because if you think about, the right-hand side where you've got spikes of estrogen going on, the HRT is just going to be adding to what's already there. And that's why some of you who might have tried HRT during perimenopause, thinking it's going to iron out all the ups and downs, actually find that the HRT makes it worse. And it's only the contraceptive hormones that will actually suppress the ovarian activity and reduce the risk of menstrual migraine during perimenopause. What about HRT post-menopause? Well, we're on a different scenario here, because actually the hormone fluctuations are pretty minimal post-menopause, and HRT can start to be effective. But in order to minimize the hormone fluctuations, we want to use stable or get as stable post-menopause HRT levels as we can. And actually to do that, the patches provide the most stable hormone levels. Gel can be useful, it's transdermal, but there can be quite a marked variation from day to day. For those women who have a womb, they will need continuous progestogen. And transdermal combined with estrogen and patches, the intrauterine system, the Mirena and micronized progesterone, that may have some advantages for migraine as well. But note, I'm not advocating that HRT is a treatment for migraine. I'm talking about when women have flushes, night sweats, they are needing HRT for management of those symptoms. How can we help benefit migraine as well as much as possible? And because HRT is using physiological doses of physiological hormones, often body identical nowadays, there is no contraindication to use of HRT by women who have migraine with aura. Risks and benefits of HRT, I really do not have time to go into that. That is I think the topic for another day, and it's not my role here to go through all the ins and outs of that. But it is important to be aware that it is for each woman a balance of benefits and risks of both combined hormonal contraception, progestogen only methods, and obviously HRT. Worth also saying, the more hormonally triggered your migraine has been through your life, the greater your likelihood of improvement of migraine post-menopause. Don't believe that migraine is immediately going to improve as soon as you've had your last menstrual period. It can take several more years to get out the other side, but essentially time is on your side in that scenario. So I'm going to leave it there and open the floor to any questions, and I will stop sharing my slides.
Thank you so much, Anne. As you may have noticed, there's been quite a few questions. So as predicted, I don't think we will get through them all, but in the remaining 20 or so minutes that we've got, we will try and get through as many as we can. So I'll hand over to my colleague Max, and she will start to run through the questions.
Thank you, Debbie. Thank you, Anne. That was really, really interesting. So we had a question about, will we get a copy of the slides afterwards? Those kind of things will be dealt with in the chat later. Yeah. So we've had lots of questions. I've tried to kind of group them as much as I can. So a couple of questions then. One is, I seem to be the only woman in my family who suffers from menstrual migraines. I would have thought it would be something that would run in the family.
It all depends on threshold. So those of you who know me, have heard me speak before, will know very much how I talk about you're born with a genetic threshold. Here's your threshold, if you like. And then we have triggers. So each trigger, you need to think of a step that will build up. And then by the time you've got enough triggers to reach whatever your individual threshold is, you will then trigger off that migraine process, that chemical change within your brain that is a migraine process that is different from just a standard headache. And it's really for each individual person, what have they inherited as their genetic threshold? So where does that stick? And also the weight of different triggers. So with the menstrual trigger, often it can depend on whether or not that individual has troublesome menstrual problems as well. That can be acting as different factors. It may also be, bear in mind that hormonal migraines are not solely triggered by hormones, so that sometimes if we completely remove the hormone cycle in a woman who has had, essentially completely almost solely menstrual attacks, it can unmask the non-hormonal triggers that will come through, and women can often find that what's gone from regular monthly long duration attacks to more frequent, shorter, erratic attacks because the non-hormonal triggers come through. So that's really a long way of going roundabout to say that while there can be a genetic tendency towards your threshold, where that threshold lands for each individual and how it couples with their individual triggers does not necessarily have to be consistent within a family.
Thank you. Next question. I wondered about the evidential links between endometriosis and migraine.
Yes, there are links. Women who have endometriosis often have higher levels of estrogen because, and certainly more of the estrogen, progesterone sort of almost imbalance, because endometriosis often feeds off estrogen. And for those of you who don't know endometriosis is where the lining of the womb can be found outside of the womb, so that it can cause extreme pain, particularly with the monthly cycle, because there is essentially ex-womb bleeding, out of womb bleeding that is occurring during menstruation as well. That is all feeding off estrogen. So many of the treatments that are used to suppress estrogen and menstrual cycle activity, but it's also been shown that women with endometriosis have a higher likelihood of having migraine with aura.
Okay, thank you. Okay, are prostaglandins affected by paracetamol?
Not very effectively, no. It's non-steroidal anti-inflammatories are much more effective on prostaglandins than paracetamol.
Okay. Is there an increased likelihood of experiencing complicated auras coinciding with ovulation and the presence of ovarian cysts?
Yes, is the answer to that one. The reason being, and I didn't really go into it in detail here, is that estrogen has a different estrogen levels have a differential effect on migraine. So while I was looking at the scenario of the falling levels of estrogen triggering off migraine, menstrual migraine, and typically without aura, we also see times of high levels of estrogen triggering or being associated with migraine aura. And the time that we often see that across the menstrual cycle is around the time of ovulation. And it's not uncommon for those women who experience migraine with aura to experience migraine with aura in a couple of weeks before they have their period when they're ovulating, and then get menstrual migraine without aura around the time of their menstrual period.
Thank you, that's interesting. Okay, so there was quite a flurry of questions when you started talking about the Prophylactic, about using it that much in a month. Could you just expand on that?
Yes, I mean, the issue here comes into what constitutes medication overuse. And so the general rule of thumb is if people are using triptans on more than 9 days a month, there is the potential for medication overuse. And I say potential, I don't say that it is definitively so, because it's not just about the number of days that you use, it's also about the patterns of those, the migraine attacks across the cycle, which is why I love those very simple diaries as well, because they show you the gaps as much as they show you the activity. If a woman is having, and the other thing to say is it's not the number of doses of triptans, it is a number of days on which triptans are being used. So if you are, let's say, using 2 doses of frovatriptan on one day and 1 dose of frovatriptan on another day, it only counts as 2 days. So 9 days of triptan use it doesn't matter, it doesn't matter what you've taken on those within those 9 days. It's a day of treatment. If you are using 6 days of perimenstrual migraine prophylaxis, and the paradigm was to use 5 milligrams, that's within the clinical trials, 5 milligrams twice daily on day 1 of the first 5 days, and then twice daily, a single dose, 2.5 milligrams on the remaining 5 doses, with the option to take an additional frovatriptan tablet for a breakthrough migraine attack. So the only issue of concern would be if somebody then also needed to regularly be treating migraine attacks on more than 3 days with treatment the rest of the cycle consistently. But even then, it's not so straightforward, because somebody who regularly has 7 to 10 day gaps between their migraine attacks will not be experiencing medication overuse headache, because that's not the pattern. So it's not just the number of days, it's also the pattern of days and the duration between treatment that we take into account.
Okay. So someone's saying, if menstrual migraine is more disabling, why is it not reflected in the NICE guidelines treatment? Because getting it 3 days out of every month doesn't trigger chronic migraine, but you can't function.
There is very little, if you look in all the headache guidelines, there is very little, I don't want to say recognition, there's very little focus or direction to management of the different scenarios of migraine, hormonal migraine affecting women at different times. You only need to have picked up the papers recently with all the focus that's now going on menopause, as we were discussing earlier with the Migraine Trust team. to know that, you know, there's an awful lot of women saying, but my migraines are getting worse as well. And we don't see that in any of the guidelines either. And I think that's something that actually needs to be fed back to the guideline people. Is, you know, 80% of people attending a menopause clinic, attending a migraine clinic, will be women in their 40s. So that speaks for itself. I don't need to say anything more on the basis of the discussion that we've had thus far.
Okay, so I'll move on to a couple about children, and then we'll go on to menopause and perimenopause. So my 7-year-old daughter suffers from abdominal migraines. Is it likely that she will go on to suffer from perimenstrual migraines? I'm a perimenstrual migraine sufferer myself.
I don't know the answer to that. Those of you who are old enough like me to have known Nat Blore, one of the medical directors at the City of London Migraine Clinic, one of his favourite, not favourite, but one of the things he used to say was, little belly achers become big headachers. We do know, we have seen some research that has shown that girls can experience cyclical abdominal migraines that seems to follow almost a menstrual cycle pattern in the years leading up to their first menstrual period. And we do see a little flurry of potential sort of menstrual migraine around puberty. Quite often, that's also the time that girls will have their first attack of migraine aura, and they may not have another attack of migraine aura for many more years, and it's because of those spikes in the hormone levels. But essentially, it is not that common for perimenstrual migraine to be a significant issue in teenagers and adolescents, unless they've got another menstrual disorder going on with it as well. It's usually much more common for women to grow into it, the natural history of it around perimenopause.
Okay, thank you. Let's just have a look. I've asked my GP for HRT, and he says the treatments available are contraindicated for women with migraine, so I'm stuck.
Nope. Direct your GP to the paper that I've written actually on the British Menopause Society website, and there is the lay organisation similar information sheet on the Women's Health Concern website. I think you've probably also got some on the Migraine Trust, that it clearly states that HRT is not contraindicated in women with migraine. We have similar issues in women who have migraine without aura, who are told they can't take the contraceptive pill, which is another nonsense, because it actually might benefit their migraine, and certainly a menstrual disorder as well. So unfortunately, there is a lot of myth out there that is not fact.
Okay, so this might be linked to that then. Are HRT treatments contraindicated in women who suffer with migraine with aura?
No, simple answer, because it would be, if again you think of these things logically, when we're giving HRT, when we're giving it in its proper indication to replace hormones that are no longer being produced, because quite often it's given as a supplement during perimenopause and not a replacement, and that will have different effects for different reasons. But when it's given as a replacement, most times we're giving body identical hormones, so they are structurally exactly the same as estrogen from our own ovaries, even though they're plant-based in their origin, in very similar doses to those that our own bodies were making as an average across our menstrual cycle. So it would be a bit like saying that to treat that the natural menstrual cycle was contraindicated in women who had migraine aura, which would be quite difficult to instigate, and is clearly not true.
Okay, I'm very conscious of time. We've got 5 minutes left, so I'll just ask some really quick ones then. So when I was pregnant, my migraines went away completely and they're back since my daughter was born. Why could that be? Could I take any sort of hormonal tablets potentially?
Yes, I think we do see a very common scenario that particularly in first pregnancies, women who have migraine without aura, particularly menstrual migraine, will find their migraine improves. A little bit different for women who have aura, and that might start for the first time during pregnancy. It is important to realize that the pregnant state is not just about estrogen. The pregnant state is also about much better pain control, much better sugar tolerance in the pregnant women, and a number of different factors that all can potentially benefit migraine. We know that post-pregnancy there will be a drop in levels of estrogen that can often trigger an immediate postpartum migraine. We know that women who breastfeed, who suppress the natural menstrual cycle, will also benefit with respect to migraine, only up until about 6 months, because by that time, even if they continue to breastfeed, the body starts gearing itself back to ovulatory cycles again. But then when you are looking after a young baby, there is sleep deprivation. You may not be, you may easily get dehydrated. You have all the constraints and things of looking after a young child, and periods often coming back again. So we know that first pregnancies are more effective at managing migraine than subsequent pregnancies. You get less benefit with each extra child that you have.
Okay, so well, thank you. I think we need to end it there, really. There are so many more questions. I think you've covered a lot of them, and one thing that might be helpful is for us to rewatch, because there was so much content in what you said, especially the biology lesson was so helpful.
You might need to run back through that a few more times too.
Thank you, and thank you to everybody for answering questions. I'm sorry if I didn't get around to yours, but there were just so many. I tried to pick ones that would be most helpful for most people.
Yeah, thank you so much. Thanks, Mags. Brilliantly asked there those questions, and thank you so much, Joanne. We really appreciate your time. We know how busy you are, so we can only thank you for joining us. I really hope everybody found that useful. Please, again, fill out your evaluation forms when they come through. There will also be a link on there and in the chat box to donate, in case anybody feels that they'd like to donate to us. We can only carry on through your very kind donations. Our next Managing Your Migraine event is on the 6th of July, and that is around the mental aspect of being diagnosed with migraine. So managing your thoughts and feelings around a migraine diagnosis. But again, thank you to everybody, and I wish you all a very restful and peaceful weekend, and we will hopefully see you all soon. Bye.
Thank you.